Just because we've survived prostate cancer doesn't mean we're bulletproof to other major diseases, and certainly stroke is one. So please welcome Dr. Watson.
Thanks very much, Bob. That's a very nice introduction. Yeah, as a matter of fact, I met Bob in the clinic probably 3-4 months ago. That's right, because as I look out on this group of people, just the general age range and the faces here are very consistent with the sort of spectrum of patients and people that we see in the clinics all the time. Unfortunately, stroke, similar sort of fashion, the way you talk about and introduce the topic of prostate disease is it's an old foe. It's an old challenge that we've faced and struggled with for many years. And up until just recently, really the last decade, we haven't had any new agents in our armamentarium as to how to deal with stroke, how to combat stroke, and how to overcome stroke. But there's been huge change in the last decade, so this is kind of an appropriate talk to bring people up to speed with. We can do an awful lot nowadays to prevent stroke, to treat acute stroke, and to assist people in their rehabilitation and recovery from stroke. So I'm just going to give a brief run-through of some basic facts about stroke. We'll talk a little bit about stroke subtypes. We'll talk a little bit about some little clinical vignettes that'll give you a bit of an impression as to what can be done about the acute treatment of stroke nowadays. We'll talk a little bit about prevention, and then I'm going to leave a fair bit of time. I gather the meeting goes until what time, Bob? What? The wee hours of the morning, right? Okay. Okay.
I want to see who won the election, though.
All right. Well, that takes the wee hours of the morning. Yeah. It's usually over by the time they've counted Quebec's votes. So we won't take very long here, but I'll leave lots of time for questions because I'm sure people will have lots of questions and thoughts. If at any point during this there's something I've said that you're not clear on, you can't understand, or you have some questions about, feel free to interrupt. We can make this a dialogue. It doesn't have to be sort of a monologue, okay? So just to start with here, stroke, simply defined, is the sudden onset of a focal neurological deficit that usually approximates a vascular territory of some type or another. Most of them are a problem with the arterial circulation, the circulation that brings oxygenated, nutrient-rich blood to the brain to sustain it. And the brain's extremely sensitive to its blood supply. Without a good blood supply, the brain starts to die, brain cells start to die in 5 to 10 minutes. There's a very short period of time for brain cells to exist without the proper supply of oxygen and the principal substrate which it uses for metabolism, that's glucose. Now, that 5 to 10 minutes is if there's absolute loss and disruption of blood supply. And fortunately, when an artery is blocked in the brain, there are collateral systems that can support it and maintain at least some blood flow to brain, which results in a persistence of the survival of brain for an extended period of time. And that's what gives us the opportunity to break up these clots, reestablish flow through normal channels, and save brain, and give people good chances for recovery from a stroke when they have one. And that's why it's so important that the instant you have any symptoms of stroke, and we'll talk about these in a little while, you make sure that you call 911 and you get to a hospital as soon as you can. It's not getting to a hospital within 2 or 3 hours, it's getting to a hospital as fast as you can. That's the critical thing about stroke. So, stroke subtypes generally break down in the following sort of a fashion here. And we can illustrate them in this sort of a manner. About 75 to 80% of all strokes are what we call ischemic strokes. We'll just say 80% of these are ischemic. And when we talk about ischemia, that's like myocardial ischemia, myocardial infarction, an MI, where there's blockage of blood flow into a portion of the brain, and that portion of the brain that's dependent upon the blood supply for bringing oxygen and nutrients dies. It has an infarct, is what we call it. So that's ischemic. Hemorrhagic strokes, which constitute the other 20%, are ones where there's a break in a blood vessel somewhere, and there's hemorrhage into the brain. So blood escapes from its normal compartment in the vascular system and bursts into the brain or the surrounding regions of the brain. And it generally breaks into two types. About 10% of these are what we call intracerebral hemorrhages, where there's rupture of the blood right into the brain substance itself and rapid damage and destruction of brain. The other is subarachnoid hemorrhages, and these are the ones with these massive sudden onset of a bursting headache that you've all had some experience with a friend having at some point in time. There wouldn't be anybody in this room who hasn't had a family member or a close friend or some association with somebody very closely that's had a major stroke. It's a very common disease. What have we got here? There we are. The outcomes of ischemic stroke, the sort of stroke that we'll talk about mostly tonight, are not favorable, actually. Only about 25% have a good and full recovery under today's conditions. If they're treated with TPA, we can get this up to as high as 35 or 40%, but only about 25% have a really full recovery. 15% mortality is still a pretty average sort of a number around the globe. We're getting it down to around 10% with some of our tertiary stroke programs in Alberta, both in Edmonton and Calgary. And out of this, a fairly sizable percentage here still ends up 60% with some form of significant disability, and 15% have very major disability that they live with. Now, the statistics on stroke are kind of frightening, actually. If we look at the incidence around the world, it varies between about 120 to 250 per 100,000 people worldwide. In a place like Medicine Hat, for instance, it has a fairly old demographic, a lot of retirees in Medicine Hat. The incidence is about 200 people per 100,000, so about 20 people per 10,000 occupants of Medicine Hat, city that's probably around about 60,000 or so, and that's quite a few strokes every year. North American incidence overall, as a general rule, is actually now it's more than 120. It's up in the range of 160. And it's rising as the aging population, the baby boomers, start to age in North America. It constitutes about from 500,000 to about 750,000 strokes in the United States every year, and about 55,000 in Canada every year. And because the fatality rate is relatively low, there's a very high prevalence of stroke survivors. That means that in Alberta, we're looking at something in the range of about 5,000 to 5,500 strokes a year, and we've got about 25 to 30,000 people living with the problems and disability of stroke. So there's a very large number of stroke survivors in the province. It's one of the leading causes. I won't say it's the number one cause of long-term disability in the adult population, but it's one of the leading causes. And the costs in Canada, for instance, are roughly $3 billion per year for stroke, without counting in the loss of productive years and just human individual productivity because of the disability caused by it. And one of the interesting things that ties it so strongly to all other forms of vascular disease is the fact that when you've had a stroke, your most likely next vascular event will be another stroke, but your most likely cause of death will be a heart attack. Just indicating the sort of unity of all these different types of vascular disease, based largely on the factors which age the arterial system. And unfortunately, we're in what is an epidemic of stroke, actually, because with the increasing age of our population, we're looking at an ever-rising incidence of stroke. And in our population right now, the incidence of stroke is rising by about 1% to 2% every year, and will do so for the next decade as our population ages. So it's a major healthcare issue. There's been a lot of changes in stroke care, as I talked about and introduced at the beginning here. And one of the big catalysts for change has been the advent of an agent that we can use to break up clots and treat stroke in the acute setting. Up until about 1986, we really didn't have any demonstrated effective therapy for acute stroke. An acute ischemic stroke, where there's blockage of a blood vessel by a blood clot, can be treated with TPA, this tissue plasminogen activator, or what you may have heard of in the papers as the clot-busting agent that can break up the clot, restore blood flow in the acute phase, in the acute time frame, and reduce the amount of damage to the tissue, reduce the size of the stroke, improve people's outcomes, reduce their disability. And I'll show you some cases just like that. There's all kinds of treatment windows that we can utilize. And the bottom line here is that stroke is a treatable disease. It's not something that we should be nihilistic about and that we should give up hope on. It's treatable at almost all levels: the acute phase, the subacute phase, prevention, and both chronic and subacute rehabilitation. Big improvements and big change coming in all aspects of it. We look now at stroke in terms of a sort of a linked chain of a continuum of aspects of stroke care. We talk a lot about acute hospital care, and I'll be showing you some case studies from this sort of a realm. This is really where I function. This is my realm, and this is why I'll sort of emphasize it a little bit. But rehabilitation is extremely important and is something that can be applied to all stroke victims. Community reintegration is an incredibly important aspect where the Stroke Survivors Association of Alberta has a big role to play, as does the rehab group in this hospital and all other stroke centers. Identification of risk factors and their appropriate management. Education, which is a branch where the Heart and Stroke Association has a great deal to play, role to play, and primary risk factor reduction. And we'll talk a little bit about this. So pre-hospital, hospital, post-hospital, it's a continuum of care, and when we make 5 and 10% gains at every one of these steps, then the impact on overall outcome is huge, and it's extremely important. It's a cause for great optimism. One of the myths about stroke is that it is a disease exclusively of the aged, and that's not so at all. About a third of all strokes occur under the age of 65, which is relatively young. It's an increasingly young age, actually, when you consider that in Canada now, the average male lives to 80 years of age, the average female to 84. This is an example of a relatively young fellow who was at work. He's a 32-year-old man who was working at his the machine where he bends metal at work, and had a sudden onset of what we call aphasia. It's just an inability to speak. So he's mute, his right side goes weak, and he slumps into his machine, and one of his co-workers immediately recognizes he's having a stroke. And this is an incredibly important aspect of the opportunity to treat, is rapid recognition in the community. Call 911. The ambulance service has all been directed that in a suspected stroke, they're funneled right to the stroke program here at the Foothills Medical Center. They don't go to the Rocky View, the PLC, or the Balzac General. They come right here to the Foothills. And this is where the stroke team resources are and the expertise to deal with these sorts of problems. So when he comes in, he's met at the door by the stroke team because we've been given sort of a bit of an early warning that there's a stroke coming in. And he gets a CT scan in short order. He's got a little bit of hyperdense artery sign here down on the left. There's a little bit of early ischemic change in this portion of his brain, but generally this is a pretty good looking scan. And his subsequent investigations with a CT angiogram show that he's got scattered emboli that are obstructing his middle cerebral artery. His angiogram actually shows that he's got a dissection of his internal carotid. So within a very short order, we've got a diagnosis for exactly what's going on with this gentleman, what's causing his problem. And in spite of his large neurological deficit, he fortunately has a good-looking CT scan, and he's treated with intravenous TPA. He ends up with a relatively small infarct in this region here, which is not particularly eloquent, and in fairly short order, he goes home within about 4 days and returns to work within 2 weeks. He also has a little bit of damage down in here, but when you look at this overall picture of the brain that was at risk, this is a guy who has an exceptionally good outcome from stroke, and he returns to a normal productive life. He has an identified cause for his stroke that's treated with antiplatelet agents for 3 or 4 months. His follow-up scans show that his artery is remodeled and is returned to normal structure and function. And he's looking at what will probably be a normal lifespan and a full productive life out of this. 10 years ago, this gentleman would have had a devastating stroke, lost his capacity to communicate and speak, and probably been an invalid at age 32 in a nursing home. Lost to his family and to any sort of a productive, meaningful life. This is another example of that gentleman was just treated with plain intravenous TPA, which can be delivered in just about any primary care center now across Canada. This is a gentleman who required a little bit more specialized care, and he's a 58-year-old left-handed fellow, and had a sudden onset of a right hemiplegia. Now, in most people, especially right-handers, their dominant hemisphere is their left hemisphere. This, you'll think I've lost my marbles, but radiologists have things all upside down, and whenever they do anything, they always seem to have it backwards. Well, in the scans here, when you look at these, the left side here, or what's the right side, is actually the left side of the brain. So you're looking at slices of bread stacked up in a guy's head. These are slices cut through the head, and it's like looking at a loaf of bread, but you're looking from his feet upwards, okay? So you're looking from his feet upwards. This is the left hemisphere. This is the right hemisphere.
Which is the front?
The front's up and over here. This is his frontal sinuses up in here. The dark stuff here, the CT scans are they're a grayscale representation of the attenuation of X-rays. There's an X-ray tube here, and then there's a sensor here, and it moves around at 360 degrees in very rapid fashion and takes these pictures, and then a very complex computer algorithm puts together a picture of a density readout. Things that are like air, that aren't very dense, the air in his frontal sinuses here, come out very dark. Things that are very dense, like bone, comes out very white. And all the other tissue types are somewhere in between. So it's a grayscale where the least dense is black, the really dense is white up here, okay? And so this is brain tissue in here. This is spinal fluid down in here. This is spinal fluid in his lateral and his third ventricle down in here. These are little specks of calcification within the brain parenchyma itself. And you can see that there's quite a gradient of different densities of tissue in here. These are some of the foldings of the brain. We call them sulci, gyri, whatever you like, and foldings out on the outer surface. So bone around the outside here. This is the bony box that houses the whole structure. And then you've got the porridge inside, okay? And these are all normal structures in here, the lateral ventricles in here. So when this gentleman comes in, he has a couple of findings on his scan. He's got a little bit of a hyperdense artery in here and down his internal carotid. But again, this is a gentleman who's come in very early. His family recognized the onset of this. They called 911, and he was in as quick as could be, under an hour. And he was a fair distance away. Again, we can have a very quick look at the arterial system inside the brain without even having to open up the box or give an invasive test. With an intravenous injection of contrast, we can follow the course of the contrast up through the arterial system, and we get a nice picture of all the vessels that in the brain here. So we can see where his problem is. He's got a big blood clot sitting right in here, in this portion of his artery here. It's blocking up this artery. And this is quite a substantial burden of thrombus, but he's got good collaterals. You can see the really bright vessels over here, and these collaterals are the thing that gives us the chance to be anything more than a rehab medicine specialist. This gives us the chance. This is holding brain sort of at bay. It's preserving it. It's keeping it going. It's not going to last forever, but it increases that 5 to 10 minutes with absolute ischemia into something in the range of 3 or 4 hours, where it has the capacity to survive for that long.
Watson, could you go back and describe in more detail what is happening on that left side? You said you kept the brain going.
So what's happening in this stroke is he has, and I'll just stand back here, and maybe you can see this a little better if I point to it on the screen here with laser pointers. So this is one of the major arteries. This is the middle cerebral artery coming to his left, the left side of his brain out here, and there's a blood clot here blocking. You see where it backfills right to there? This area where there's a cavity, there's a gap in the contrast, that's a blood clot actually, sitting right there in his arteries, blocking his artery, blocking the blood supply into the rest of his brain. Fortunately, from other arterial sources coming around from the anterior cerebral over the top, he's filling a lot of these other arteries that otherwise would be relatively empty of blood, and this is keeping this portion of the brain alive. It's keeping it going. But it's only going to keep it going for a certain length of time if we can't break up this clot. I'll show you another picture of this that makes it No trouble. Makes it a little bit clearer. I appreciate you asking that question. There were probably a half a dozen people in the audience wishing that they had. Now, can you see the pointer well enough here? So there's the cutoff of that artery with the blood clot before we intervene and try to open this up. Here's some of the other arteries, and these are the collaterals that are coming down over the top here to supply this brain and keep it going. And you can see they come down right over the edge here like this, but you can also see there's an area here that doesn't have the sort of grayness from the contrast material, which is an indication of the blood flow to the brain and the brain parenchyma. So this is the sort of area of the brain that was going to die if we can't open this up. But fortunately, with intra-arterial techniques, feeding a catheter up through the artery here and putting the TPA right into the blood clot. In this instance, we were able to break up this clot quite rapidly. And this is the picture of his arteries after that's happened. And this artery that was cut off right here is now open, and he's fully perfusing this brain. And he, like the other gentleman, has an extremely good outcome and just has a little hole in the cheese down here. And likewise, he walks out of the hospital and returns to his normal work within a couple of weeks. So he's an example of what happens when you have an extremely well-organized, coordinated team with stroke neurologists, emerge docs, neurointerventionists, people who can utilize these catheters, deliver the TPA right into the clot, break up the clots mechanically, and restore the flow in a very short period of time.
Could you tell me how they get the TPA to the clot? Like, where do they insert it?
In most circumstances, we just give it into the vein. It's given as in a set dosage with about 10% of it as a bolus, just squirt right in there, and then it drips in over an hour. And so it's a systemic delivery of the TPA, circulates. It's got a very short half-time of about 5 minutes, so that almost all of it's gone. When we stop the infusion, it's almost all gone within about 25 or 30 minutes. So it's fairly short-lived. It's fairly fibrin selective, so it tends to concentrate at the site of the clot where the fibrin is being formed, and helps break up the clot. But when you've got a big cigar-shaped piece of clot and you give it systemically, it really only gets to hopefully the two ends of the clot, and sometimes really just the one. So you're looking at a cylinder where you've really only got exposure of the two surface areas at the ends. If we stick a catheter right into the clot, the blood clot, and lace it with TPA, we get a much expanded degree of exposure of the TPA to the volume of the clot, and you have a greater chance of breaking it up, about twice as much chance of breaking up the clot. The clot, no, just like they would do an angiogram. I'm sure you've probably got someone in the family who has an angiogram, and there's many people here who have probably had angiograms. And the catheter is fed in through a large artery down here in your groin, your femoral artery. And you just put your hand down there, you can feel your pulse beating away. And it's just a groin puncture with a little bit of local anesthetic, and the catheter is slid in up your aorta, up here to the arch, into the appropriate vessels. You don't really feel it at all, actually. It's just sliding up the inside of you don't feel it any more than you feel the blood circulating in your vessels right now. It's just fed in there into the thrombus, and then the TPA is administered to the clot. Okay? It's a fairly slick procedure, actually.
Question: once you start that procedure, how long does it actually take you to get the delivery right to the clot?
Well, we were doing one last night about I guess between 1 and 5:30 a.m. And it took about, from the time you get the team in and everything and the patient over there, it takes about, maybe 15 or 20 minutes to get in there. It's not long, actually. And if the team happens to be in the hospital, and this is in the middle of the night, if it happens when everybody's in here and at work, then it can be quite quick, quite rapid. So it's one of the problems. You have to have a very organized team. You've got to have a very slick operation to get it done very quickly. Time is extremely important, really important. Yes.
Just had a question. The clot could come from anywhere in the body, but it only causes a problem once it jams something up in the brain?
That's right. Yeah. Well, it causes problems in other places too, but you're right, and you're sort of getting at one of the distinctions between strokes and heart attacks. Heart attacks, 95% of heart attacks occur as a result of a change in the arteries right in the heart. So they occur on what we refer to as the substrate of an atherosclerotic diseased artery. Usually there's rupture of an unstable plaque or just enough inflammation in that plaque that the blood starts to clot right there in here. And the clots don't come from outside, they come from the coronary arteries themselves. That's where their problem is. So that's fairly straightforward. You have a blocked artery in the heart, you know the problem's 95% of the time right there in the heart. In the head, the clots can come from a variety of places. They can come from blockage of diseased arteries in the head, and a sizable number of strokes do come from that. Probably something in the range of 40 or 50% happen that way. But a very large percentage also come from emboli, clots that form in big arteries out here on atherosclerotic arteries, and then flip off and float up into the noggin. Clots that come out of the heart, and then float off and head north and cause strokes and block arteries. So there's a lot of other possibilities and a lot of other diagnostic considerations that have to be taken into account, and a lot of diagnostic testing that has to be done when someone has a stroke in order to identify the source of that stroke. Yeah. Okay? This next one is an example of what can be done when you organize a stroke system on a provincial level and develop a means of handling these strokes and extending the level of care that's available in tertiary centers like we have here in Calgary and in Edmonton out to the smaller centers and smaller population places where there aren't stroke neurologists, there aren't the sort of facilities, and there isn't the sort of expertise to deal with it locally. This was a 41-year-old person who suddenly slumped down at work in the early part of the morning, and with a right-sided paralysis and the loss of speech, which is symptomatic of a big, large left hemispheric deficit or a large hemisphere stroke from an arterial blockage. And this happened in Medicine Hat, actually, and she was initially brought into their scanner and seen in the emergency room about 25 after 8, and there was quite a delay because of not because there was a problem with recognition. She actually fell behind a door and was wedged in a bathroom, and they had a terrible time getting her out, actually. So there was an hour and a half delay just getting to the hospital, which is a big problem. The stroke team was contacted, and she was transferred to the Foothills Medical Center. This was before the days when we actually had a telemedicine link with Medicine Hat and with Lethbridge, where just in the same sort of technology that you see on TV when they're talking to Christian Amanpour out in Kandahar, and you know her picture's breaking up and everything like that. Well, we have a little faster transmission speeds. We've got nice, clear, crisp pictures, and we can talk to the patient, examine the patient with the assistance of the physicians there, and look at the scan, and we can assist them in making decisions as to whether or not this patient should be treated with TPA right there in Medicine Hat without any time wasted. This was before those days, but fortunately this benefited her tremendously. With a rapid transport in a fixed-wing plane, she arrives 2 hours after her arrival in Medicine Hat in Calgary. She's got a big neurological deficit. That's all that number really means. She's paralyzed on the right side, and she can't speak, and she can't understand anything we say to her. She has some findings on her CAT scan, which is similar to some of the other cases. This is a bright signal here that indicates a fresh blood clot sitting in the artery there. We won't belabor too many of the other aspects of this scan, but she's got some early ischemic change down in here, some early damage. You can see that it's nice and bright over here because that's what gray matter should look like in that area, and it's become kind of dark in here. It's started to approximate the dark color of white matter, just indicating damage and loss of nerve cells. When we do the angiogram on her, we can see that she's got a partial blockage here in her middle cerebral artery. This is a filling defect. The artery comes along here, and then all of a sudden, oops, there's a bit of a cutoff in here. And she's got a major problem with the circulation. You can see it right down in here as well. Fortunately, although she was beyond the sort of time window when we usually give TPA, we have other devices that we can use. And this one here, you can, I don't know whether you can see it clearly at the back there, but you see this little corkscrewy looking device? Well, this can be fed up through that catheter as well, and then it's just deployed out of the catheter right into the clot. And so this just embeds in the clot, and you can pull this back out of the artery and bring the clot with it. So there's another example of a technique that can be utilized to try and remove some of these clots. And when that's done, this is her. This is the big filling defect here before her. What we call a Mercy device was used. This little corkscrew, and this is after the corkscrew's been in and pulled it out, and you can see that she's got lots of vessels filling in there now, and she's really had a really good return of blood flow to her brain in that area. She goes home with, again, there's a bit of a hole in the cheese, but in fact these are relatively minor neurological deficits, and again, she had a little bit longer rehabilitation, but she returned to work in about 4 months to a normal productive life at 41. Okay, so these are just examples. They're vignettes that give you a little bit of a sense as to what can be done. People can be treated acutely with IV tissue plasminogen activator with their clots broken up and return of perfusion to their brains with good outcomes, and that can be done in all of our primary stroke centers across Canada and throughout Alberta. In tertiary centers like ours, we have the option of some of these catheter-based methods of delivering the TPA right into the thrombus, or using some of these mechanical devices to actually pull the clots right out and remove them from the circulation and restore normal flow. So there are a lot of things that can be done, but the key thing is people have to get to the hospital in time for us to be able to do them. If they've already got well-evolved change in their brain, and they get here at 4 or 5 hours from the onset of their stroke, it's too late. We haven't got anything to offer, actually. And then we become rehab medicine specialists. Okay? This is emphasized here in this slide here. Time is brain. And this is just a good example of the benefits for TPA and for revascularization, for recanalization. If, along this red line, you get into the hospital and you're treated within 60 minutes, you have 4 times the chance of having a good outcome than walking out of the hospital, like an excellent outcome. If it's 2 hours, that falls to about 2.5 times the chance of an excellent outcome. And by the time you get down here to 3 hours and getting beyond 3 hours, we're starting to get down to what is almost neutral in terms of benefit of TPA. It's almost nil. So time is extremely important. This is almost exactly the same sort of time benefit curve that you see for treatment of myocardial infarcts and revascularization of the heart, either with angioplasty acutely or with TPA, TNK, these same agents. It's a very similar sort of a concept, okay?
Now,
Mm-hmm.
I heard like that you had to have the TPA within 3 hours, but there was something in the paper recently that said that now they can do it up to 4 hours and have good results. You're saying you don't get much result in 4 hours.
You do in selected cases, actually. And you guys are all so sharp, you know. You're just you're as bad as my wife, you know. I wake up in the morning listening to her tell me things like, "Have you read that article on ginkgo biloba that came out in the Calgary Herald and what it benefits?" I can't spell ginkgo biloba, but we know you're right. And this is I was just at a meeting in Vienna where the results of the ECAS-3 trial were presented by Werner Hacke about the success of treatment in the time window between 3 hours and 4.5 hours. And although it's not as good as when you treat earlier, there's still demonstrable benefit, even when you look at a large population of stroke patients and do it in statistically significant fashion against an untreated cohort. So it's a randomized controlled trial with a blinded observers and a placebo-controlled cohort of patients. So yes, there is. And benefit, there are cases in patients where we've treated even beyond that. But the further you go from the onset of that, the less the likelihood that you're going to be one of the very few people who will benefit. And what really determines whether you're going to be one of the lucky ones that benefits is the shape of your collaterals, how good your collaterals are. And a lot of that relates to what your risk factors are. If you've got a really high, poorly controlled cholesterol, your collaterals are generally poor. They don't respond well. If you're a smoker, your collaterals are poor. They don't respond well. and you have what we call endothelial dysfunction. If you have diabetes that's poorly controlled, your collaterals are crappy, your time window is short, and your potential for benefit is lousy. So it's this stroke prevention aspects also play into your potential for benefit from acute therapy.
And what is it they do again that tells them that it's a hemorrhagic stroke? Is it
A CAT scan, just a CAT scan, yeah. Blood shows up right away on a CAT scan. It shows up as a bright spot. It's very easy to pick up. That's one of the big reasons a CAT scan's done, okay?
Excuse me? Is it still you can't use this TPA if you're taking Viagra?
No, we wouldn't worry about that. I suspect half the strokes are men, so about half the population's on it anyways.
It's one of the things they said years ago, that if you were taking Viagra, you can't be treated for stroke.
No, there's no problem with that at all. There's very few medications that make it, that are a barricade for treating with TPA. The main one is anticoagulants, Coumadin or warfarin. And if you're fully warfarinized and you've got a therapeutic INR around 2.5 or so, we can't really give you TPA because the chance of you hemorrhaging is so high. But the vast majority of people who are being treated with warfarin and Coumadin have atrial fibrillation or some cardiac cause. They have cardiomyopathy or a valve problem or an artificial valve. And usually when they come in with an ischemic stroke, it's because their Coumadin level has fallen, their INR, and for people who are taking Coumadin, you know what I mean by an INR, the indicator of whether or not their coagulation is adequate or not has fallen as well. So they're basically not therapeutic. They're not being therapeutically anticoagulated. And when it falls down to below 2, it really doesn't do very much good. So the vast majority we see who are on Coumadin, we end up treating as well because we get their INR back, it's subtherapeutic, and we go ahead and we treat anything below 1.7.
So what are the chances of somebody who's on Coumadin of having a stroke?
Well, for most people who've got atrial fibrillation or they've got a mechanical heart valve, it's substantially higher than the average guy on the street. I can't give you a number just off the top of my hand, but for atrial fib, generally, for uncomplicated, untreated atrial fibrillation where you're not on Coumadin, your chances of having a stroke are in the range of about, it averages around 5 to 10% per year. For atrial fibrillation with rheumatic valvular heart disease, then you're starting to look at incidence of around 10 to 25% per year. So a very high percentage. When you put them on Coumadin, the risk of that stroke drops by about 80%, but it's still higher than the average person on the street. But for any of you that are on Coumadin, or your friends or family members, wives, husbands are on Coumadin, it's extremely important to check that INR every 2 weeks. That test costs $4. Every 2 weeks. That's 4 times 20. It's just a little over $100 a year. And it costs over $1,200 a day for a hospital bed, for you to bunk into the Klein Hotel and take up a bed here. So it's a really good investment, really an excellent investment. And they can fluctuate so much. You know, if you miss, you're off traveling or something, you miss your 2 weekly, well then you end up doing it once every 4 weeks. That's still okay. If you're doing it every month, as many patients do when they start to get stable on it, and you miss that, it's once every 2 months. Then you're starting to get into the range of a lot of our customers who end up in the emergency room who have the subtherapeutic INRs. And that's a big problem. Huge problem. Yes?
As a preventive thing, you know, the simple one, baby aspirin, how effective is it and when can you overdo it?
Well, you can't really overdo with a baby aspirin. I usually have most of my patients on 2 baby aspirins because I think it's kind of, I just feel a little better on it. There is a bit of a dose-response curve with aspirin. It drops your stroke risk, your relative stroke risk by, let's say, 20%, roughly 20%. Your absolute risk of stroke drops by what sounds kind of paltry. It's only 2% per year. But a relative risk reduction of 20% is pretty substantial. There's very few other things that do as much as that, actually. And everybody over 60 should be on an aspirin a day.
Except if you're on Coumadin, right?
Except if you're on Coumadin, that's right.
I'm over 80 and my wife has had me on that for 20 years, and I cut my finger doing the turkey yesterday. I bled like stuffed pig, like the aspirin. I thought,
No. You should be on 2 aspirins. You should just, that's right, low dose aspirins. You can't say baby aspirins anymore. Yeah, delayed or rapid release. It's such a small amount of aspirin. Very few people have any troubles with their gut. 81 milligrams is what it is. And the standard sort of typical dose is 81 milligrams, 81 milligram aspirin per day. And for men and women over the age of 60, it generally results in a significant risk reduction for both myocardial infarcts and for strokes. And it has a very small sort of risk profile.
When do you move from 1 to 2?
Yeah, go back to the aspirin. Pardon me?
When do you move from 1 aspirin to 2 aspirins?
Well, I mean, it's an arbitrary sort of a thing. From my own feeling, I feel there is a little bit of a dose response. I generally have people on 2. I think a lot of cardiologists do too. It's still a small dose. You know, a lot of the old, some of you guys remember some of the old days, just 20 years ago, we used to treat people with 325 milligrams of aspirin for stroke 4 times a day. So that was a real belt of stuff.
What happens if I'm over 70 and I don't take no aspirin, haven't taken aspirin all my life?
Well, it's a good,
But I have a high blood pressure.
Yeah, but the large controlled epidemiological trials show quite clearly that, especially if you've got high blood pressure and additional risk factors, you should be on an aspirin.
What about TIAs?
We're going to talk about those in a minute, and we're going to talk about his high blood pressure too.
If you come to my house and I'm on Coumadin, and do you give me a shot of vitamin K, or what do you do to?
What, if you're having a stroke,
Yeah.
and your INR is therapeutic, it's 2.5 or something like that. No, we can't reverse it that quickly. The vitamin K takes about 24 hours or more to work. Even the fresh frozen plasma takes a long time, and it's like taking from Peter to pay Paul. Yeah, is what it's sort of like. It's not a really effective way of doing it. So it just means we can't treat you if you're having ischemic stroke. But people with therapeutic warfarin levels very seldom have ischemic strokes. Their problems with strokes are related to their INR getting too high, and they have hemorrhages, or it gets too low, and the condition that they're being treated for isn't effectively being treated, and it forms a clot in the heart, and out it goes, and they have a stroke. Okay? Okay. So, warning signs are a really important thing. You'll see the 5, you remember the hand business with the Heart and Stroke Association and everything like that? Well, how many people here remember what the 5 warning signs of stroke are? I bet you guys have seen them a dozen times. There's 3 of them up there for you. What are the other 2? Great, I'm glad you haven't remembered them, because they're not really all that important. These are sort of organized in order of importance. If you don't remember anything, just remember sudden onset of weakness or loss of function, okay? A hand that suddenly doesn't work and you can't pick up your coffee mug with, or that you're stumbling with your pen with, or an arm that slumps at your side. This is really important. When you have sudden onset of weakness, it's usually down one side. It can be face and arm, can be face, arm, and leg. It can be just leg, it can be just arm. Any episode of sudden onset of weakness is the number 1 sign of a potential stroke. And even if it's transient and goes away in 5 to 10, 20 minutes, that's a TIA. That's a transient stroke syndrome. We should have called it TSS. And that's every bit as important as if it doesn't go away. You still come to the hospital, okay? You don't scratch yourself or your head and say, oh, I wonder what that was, Ethel. Shucks, and roll over and go back to sleep, and or turn the page and carry on with your book. No, that's your chance. That's your chance to get in here and have something definitive done. First of all, have a diagnosis made as to why you had that happen, where that clot came from, and then have it prevented from moving on to a big stroke. So transient stroke syndromes, TIAs, which you were asking about, are just exactly the same mechanisms as big stroke syndromes. It's just a different size, different magnitude, okay? We'll talk about them a little more in a minute or two. But sudden weakness, number one. Yes?
You end up in the emergency area on your own 2 feet, having had one of these symptoms. How do you get their attention?
The minute you tell them that you've had a sudden onset of weakness on one side, the triage nurses are all trained for this. And that's treated the same way as if you walked in and said, geez, I just had my first episode of horrendous chest pain. It lasted about 15 minutes. I thought I was going to vomit. Had to sit down in the chair. It was pale as a sheet. And they say, holy mackerel, that guy, he's having a heart attack. Well, they recognize this sort of stuff as stroke. And you get right into the back. You don't sit out front in the waiting room for 3 or 4 hours or 5 or 6 days or whatever it is. And you get priority treatment. So you get zoomed right in there. They call us immediately, and somebody's at your bedside looking you over in 5 to 10 minutes. That's the CTAS criteria for how we deal with stroke.
That's comfortable.
Yeah. It's got the same priority as acute myocardial ischemia, heart attacks, angina, okay?
Is this
How
just
about
at this
blackout?
hospital?
Pardon me?
Is that procedure at this hospital, or is it?
Well, it's certainly at this hospital, and it's taken us a long time to develop it to this level, but we've got a complete buy-in from everybody, from the paramedics right on up. In fact, when the paramedics pick you up and you've called 911, they call us, and we're usually waiting in the emergency room to see you guys arrive. You guys come to see us, the strokes team. You generally don't even see the emergency room doc. And that's why another reason for calling 911 and coming in the ambulance. Not, walking in from the Sears Mall or calling a cab or driving in yourself, as some people do. This is the time to call 911. You've been paying your taxes for a long time. So this is the way to get your expedited route to the hospital and to a quick assessment. Because time is everything in this game, okay? Yes?
How about blackout? When you suddenly, all of a sudden, you read the paper and you go blackout for 5, 10 minutes. What happens then?
What do you mean, you just lose consciousness and slump forward?
You didn't lose consciousness or nothing, you just goes blackout then.
Well, by blackout, you mean you've lost your vision, it's blacked out? In one eye?
No, altogether. You're feeling too, isn't it? Yeah, I'm feeling too.
Well, there's a whole lot of different causes for blackouts. Sudden onset of a loss of consciousness is frequently cardiac in origin, actually, but it can be a faint, it can be a seizure, it can be all sorts of stuff. There's a tremendous group of, but that's something you should definitely come to the hospital. You call 911 and come in and have a doctor assess you and sort out exactly what's going on there. Get a cardiogram and a chest x-ray and make sure you haven't had a pulmonary embolus or a seizure or a heart attack or a sudden cardiac arrest and arrhythmia, all sorts of things like this, or possibly a brainstem stroke, okay? So that's a little bit more complicated thing, but weakness, sudden weakness, remember that one, okay? Sudden loss of speech, and the disturbance of speech is sometimes garbled speech and a mouth feeling as though it's full of marbles or porridge and you just can't, or like you've had a couple too many, but you've never had a couple too many, and that, or you just can't speak. You have a sudden arrest of speech. You know what you want to say, you can't say a word. You can't communicate to somebody, or what they're saying makes no sense to you. So it's really a major problem of communication. Sudden onset, stroke, sudden, just like the word implies. It's almost always sudden. And that has tremendous implications. As you remember in some of the stories that I told you about our stroke patients, I think 2 out of the 3 had sudden onset of speech deficit, what we call aphasia, and they had weakness, paralysis. Can everybody hear my voice? Can you hear me clearly enough? Okay. Okay. If you don't hear me, just speak up, okay? The third one is sudden loss of sight. So you can think of sudden loss of strength, sudden loss of speech, sudden loss of sight. It's the S disease, stroke, okay? Sudden loss of sight can take 2 forms. You may suddenly lose awareness of one side of your sight, the left side or the right side. And it'll just seem like an absence of images. You won't be aware of things. You'll be bumping into the door jamb on one side. That's the sort of speech or sight deficit that you get if you've got an occipital stroke. The other one is a form of sudden loss of sight which is why I asked this gentleman if it was one eye or both. It's a sudden darkening out or blackening out of vision in one eye. We call this amaurosis fugax. And in a sizable number of people, this is related to a very tight narrowing of the artery in the neck, the carotid artery, that diminishes the blood flow to the eye and results in a loss of vision in the eye. Usually it comes back over the course of 1 or 2 minutes, and it's just like the veil being lifted and the vision starts to return. Sometimes it stays blacked out. When you start having these monocular, one eye blacking out, and you'll tell it really simply by just covering your good eye, and if everything's black or it's grayed out and you can't see anything, that's what you're having is monocular visual loss. This one's all normal, this one's gone black, okay? That's what we call amaurosis fugax. That's a very important symptom as well.
I had 16 of those in one eye.
You've had which?
It was gray, and they lasted for 30 minutes.
And
16, and my ophthalmologist said, if you got your sight back, I guess it's okay. But they diagnosed it as temporal.
geez, my clinic's filling up already here. This guy in the back's going to take a week to sort out. I'll give you my business card after the meeting here. Okay. When did you have these?
10 years ago.
You had temporal arteritis? Yeah, that's a very common cause for this, actually, temporal arteritis.
It's a difficult thing to treat.
Yeah, you're still on prednisone?
Sorry?
Are you still on prednisone?
No, 5 years, but I feel a lot of symptoms again.
Yeah, okay. It's something that somebody's watching and keeping an eye on?
No.
Well, do you have a family doctor?
The DSR doesn't even show any rating.
Well, that's good. That's really what he needs to be following is your ESR.
Even if my ESR is normal, my symptoms are different.
Yeah, your symptoms maybe, but I'm sure your ESR was probably high when you had temporal arteritis. Yeah. But that's certainly something that needs to be followed up. Was there another question up in here? No?
I just wondering if you do a lot of exercise, is there any way preventing that weakness and speech loss and loss of sight?
When this occurs?
Yeah. No, after, before it occurs. Can you do it? Can you prevent it in any way?
Yeah, well, we'll get to that. Yeah, this was my fall guy. I'll get you that 20 after the... So here we're getting to the things you can do to try and modify your risk factor profile, okay? There's 4 horsemen of stroke, really. And by far the most important of these 4 horsemen is high blood pressure. Number 2 in line is smoking. 3 is probably diabetes. And 4 is an elevated cholesterol level. So those are the real 4 biggies. But these are a whole spectrum of important things. So hypertension, for people with high blood pressure, your risk of having a stroke is about 4 or 5 times normal. And really, it's a fascinating sort of a phenomenon. It's an ever-rising risk with increasing blood pressure. Your risk rises constantly. There's no place at which there's sort of a step function and you fall down to baseline and you're A-OK. So the person with a systolic blood pressure of 180 has twice the risk of the guy 12 millimeters of mercury systolic below that. 158, or 180, 168. So, and he has twice the risk of a stroke of the guy who's at 156, 12 more millimeters below. So every 12 millimeters of systolic pressure you drop your risk by half. And even the patient who's 140 on 80, and most people won't treat as being hypertensive, has a higher risk of stroke than the woman who's got the nice low blood pressure of 120 on 70. And ideal blood pressure is now defined as 115 on 70. It gets lower and lower all the time. All people with diabetes should have a systolic blood pressure consistently below 130. So we're very aggressive about blood pressure in people who've got other additional risk factors, particularly diabetes. There's no more important risk factor than high blood pressure. It's estimated if we treated high blood pressure properly, we could reduce the incidence of stroke by 50%. 1 in 8 people worldwide, the WHO statistics indicate that 1 in 8 people worldwide dies of a hypertension-related cause of death. So if you've got high blood pressure, you've got to be in to see your doc, you've got to take those pills, and it doesn't matter if you feel like you're eating a handful of Smarties every day. You've got to get your blood pressure down. It's really important. This is something you can't just do with will, and you can't just say, well, Uncle Bert, he lived to be 165, and that was about the same blood pressure he had. You know, that doesn't help. Blood pressure has extremely strong correlations with all forms of vascular disease and your risk of myocardial infarcts, your risk of stroke, your risk of peripheral vascular disease, your risk of kidney disease, your risk of aortic aneurysm. Every form of vascular disease you can throw into the pot is strongly related to hypertension. So it's one of the most important things. And over 80% of the population, when they reach your guys' age, has high blood pressure and requires medication for it. So extremely important, okay? How many blood pressure medications are you taking?
Me?
Yep.
Just one. It's fine. It goes 5, then goes to 10, then goes 15, then goes down to 5 again, my doctor. So that's yours.
Okay. What you're on. One of the other important things is you can monitor your own blood pressure at home. For a reasonable price, somewhere between 80 and 150 bucks or so, you can get a good blood pressure monitoring device that you can take your blood pressure on a regular basis at home, so you know what your blood pressure is. For those of you who may have a really low blood pressure, that may not be important, but if you've got blood pressure that's a problem and needs to be managed and treated with medications, it's a good idea to get it at home. It's not good enough to see your doctor every 3 to 6 months or once a year. That's just not enough.
And you can get a prescription and maybe your health plan will pay for it too.
Oh, sure. The vast majority of antihypertensive agents are all paid for with Blue Cross and on most plans. Yep.
What if it spikes, your blood pressure spikes from normal to...
Yeah, if you have labile hypertension, there's medications for that too. Generally, beta blockers are a good bet for you. There's a variety of medications. You want to have your blood pressure, you don't want to have blood pressure that's spiking into high range and stuff. And if you have labile hypertension that's up and down a lot, then one of the more useful ways of picking that up and getting a sense of what your average daily blood pressure is to have a 24-hour blood pressure monitoring. And you can have that done for 24 hours. We know then that some people have high blood pressure when they're sleeping. Some people have it in the morning. Some people have it in the late afternoon. Some people, perhaps like yourself, are very prone to spikes in their blood pressure. And they spend a lot of their time hypertensive during the day. So that when they lay down for 5 minutes and relax in a doctor's office, it's not a very good representation of what their blood pressure is for most of the day. Okay? So blood pressure is extremely important. Heart disease, if you have heart disease, if you've had heart attacks, if you get angina, if you have atrial fibrillation, this irregular heartbeat, or if you're experiencing palpitations, that irregular heartbeat that comes and it feels like a butterfly fluttering in your chest or a fish flipping over in the chest. It feels a hollow sort of a sensation. And if those are persisting, everybody has a few odd beats like that every once in a while. And you just get a little funny feeling in there, then it's gone. But if it's persisting for minutes at a time, and especially if you're feeling a little short of breath and you have to sit down with it, that's something you need to see your doctor about. Make him aware of that, because he can monitor that heart rate with a Holter monitoring device you can wear for 24, 48 hours, even a week. And we can make that diagnosis. Because atrial fibrillation, one of the more common disturbances in the heart rhythm, is responsible for half of all the cardiogenic acute strokes. Half. Related to a rhythm disturbance that we can pick up just by feeling your pulse. And in the age range over 70, over 10%, 10 to 12% of the population has atrial fibrillation. And it tends to be a rhythm disturbance that's associated with bad strokes. In the heart and in the atria, where this is just wiggling like a little bag of worms instead of expelling blood like this, there's sort of ineffective flow, and it just wiggles like a little bag of worms like this, and there's ineffective flow. Stagnation of blood flow results in the formation of clots. Clots form, and then the atria contracts, out goes the clot, heads north, causes a stroke. And they tend to be well-formed clots, big clots, and they cause big strokes, bad outcomes. Never in this hospital on the stroke program is there a time when we don't have at least 10 people with atrial fibrillation-related strokes in this hospital. I seldom go a day without seeing one.
If you have a heart murmur situation, is that?
It can be. Yep. And heart murmurs, just because you've been told that your heart murmur when you're a kid is benign or it's nothing to worry about, or maybe you were told that when you were 30, heart valves do this throughout your life, about that frequency. You can imagine what your hands would be like after a period of time. You'd have fingers that would be about that wide, and you know, everything started to break down if you were doing that constantly, all day long, 24 hours a day. The heart valves are a phenomenal structure, but they do wear out. And if you've got a heart murmur indicative of a valvular dysfunction at an earlier age, some of these things need to be followed up, because valves degenerate with time, especially if they've got a problem with them. So if you have a heart murmur, if you've had valvular heart disease picked up in the past, it's something that you don't just forget about or just let sort of slip under the carpet. It's something that should be followed up. It should be seen, and your family doc should be, you know, keeping an eye on that. And you can easily do that with a cardiac echo, which gives a very nice picture and impression of the valves and their function, and is very easy to quantitate and to follow over time.
What's a heart murmur?
A heart murmur? It's a simple thing. When you've got an old house and you turn on the hot water tap and it whines, and you can almost feel it hum in your hand if your hand's on the tap. Well, that is very similar to what causes a murmur. A murmur in an artery, when it's roughened and the surface is causing irregular turbulent flow, which starts to generate vibrations, which basically create sound, which causes us to be able to hear a murmur. And irregular sound over a roughened or stenotic heart valve, that causes a murmur. That causes a heart murmur. So it's an irregular flow. It's flow over an irregular or diseased surface. Okay. Well, we listen to your heart. Doc always listens to your heart. That's the crudest way of picking it up. But if you've got one and it's something that needs to be followed a little more sensitive technology and a little more objective way of evaluating it, then a cardiac echo is the same sort of ultrasound that's used to tell whether you're pregnant or not, and that kind of stuff. You do this over the heart and you get the same impression of structure on the heart. Okay? Cardiac ultrasound, it's called.
How long can you have a high blood pressure? A friend of mine's got 185 over 150 for 40 years, but he's on doctor care and still living.
Well, he's running a risk with blood pressures like that. His risk of stroke, and the sort of stroke he's most likely to have, is a big intracerebral hemorrhage where the vessel bursts. And his risk of that kind of a stroke is probably at least 10 times the risk of someone who's got a blood pressure in the 120, 130 systolic range. It's huge. You know, you can sort of dodge a bullet for so long, you know, or you can trick the devil for only a certain period of time, but eventually we get to see him. I don't want you thinking of me as the devil, but... Okay, so we've talked a little bit about some of these. Smoking, if you smoke, quit. It's the worst thing you can do. It knocks off the cells that line the inside of your vessels, these magic cells called endothelial cells that have this beautiful relationship with the blood clotting mechanism, and they keep it all in tow, and they keep it all quiet and stable and everything. When you nick yourself with a razor and that endothelium's disrupted and there's exposure of collagen, those blood clotting elements come there and they clot and stop it and seal it all up and everything like that. That's wonderful. But in the normal state, your intact arteries, that endothelium prevents the blood from clotting in inappropriate places, forming clots, blocking arteries, causing strokes, heart attacks, all that stuff. Smoking kills off those endothelial cells, makes them dysfunctional. And then you start to get these clots. And it's one of the more common risk factors we see in young strokes. They may have nothing else, no high blood pressure, no abnormal cholesterol, no diabetes, but they smoke. And they get strokes. Every one of you women, I'm sure, has been told by your doctor at some point in time the risk of being on the birth control pill over the age of 35 and smoking, right? And you get that combination of risk factors and your stroke risks just start to escalate like this. And your chance of having a heart attack too, okay? These are relative risk. It's an increase in your relative risk of 1.5 to 3 times normal. If you've got high cholesterol level, a relative risk of about 2 times normal. Smoking, up to about 3 times normal. And it's very dose related. Sorry. We talked a little bit about the unity of this whole concept of vascular disease. Strokes are part of the whole picture of vascular disease. They're related to myocardial infarcts, peripheral vascular disease, kidney disease. Basically, a stroke in most instances is a vascular disease with a neurological presentation. A heart attack is a vascular disease with a cardiac presentation. It's just the names and the subspecialties that deal with these really just relate to the end organ where the vascular impact is felt the greatest, okay? But it's all very much interrelated. The same risk factors for stroke are exactly the same major risk factors for a heart attack. And they're exactly the same risk factors for peripheral vascular disease. Yes?
You're using the term vascular quite a bit tonight, and you've always talked about arteries. Do you get any blockages in veins and what's around the lungs where you don't get a gas-to-gas exchange and have a problem?
Yeah, venous disease is quite a different sort of spectrum of things. It causes things like it's caused by things like pulmonary emboli. In the brain, we see occasional stroke syndromes, which we refer to as venous sinus thrombosis. So when the same sort of thing that can cause phlebitis and clots in the leg, and they break off and go into the lungs, can cause clots in the venous side of the brain as well, but they're uncommon.
So when you use the term vascular, you're talking arteries now?
Mainly, yeah. And there's this big overlap between coronary artery disease. So really a lot of the patients that I see in the clinic have been seen by the people in the heart disease, coronary artery disease clinics. They've been seen by people over at the Peter Lougheed dealing with the peripheral artery disease group. And they're often seen, the other group that should be down here is the kidney disease, the nephrologists, because over half of renal failure is related to vascular disease of the kidneys. One of the big myths out there is if you ask most Canadians, they think that the #1 cause of death is cancer. And it's not actually, it's vascular disease. It's heart attacks and strokes and peripheral vascular disease related to this disorder called atherosclerosis or atherothrombosis, if you like, and it accounts for roughly 30% of all adult deaths, and is actually the if you sum up the first, or it's almost equivalent to the next 5 major causes of disease all added together. So vascular disease is a huge, huge issue. And it's related to this whole business of these endothelial cells, these wonderful little cells that line the arteries. Under certain conditions, aging is #1 in terms of breakdown of their function, but it's accelerated by the 4 big risk factors: the high blood pressure, the smoking, the diabetes, and the high cholesterol. And you get this whole series of breakdown of their function, development of cholesterol, lipid sort of moiety and plaque in here, which becomes inflamed, attracts a number of platelets and white blood cells and inflammatory cells, macrophages, all sorts of elements of the inflammatory cascade, and establishes a very big inflammatory plaque. And then when this plaque ruptures, if it ruptures in a coronary artery, you get a heart attack. If it ruptures in an artery like the carotid artery supplying the brain, similar to what happened to this gentleman we were in the angio suite all last night and this morning taking care of, then he ends up with a big stroke. Big blood clots form, and then they hit up and block off arteries. Okay. Let's just talk about hypertension a little bit more. 1 in 8 deaths worldwide, #1 risk factor. If it's a horse race amongst the risk factors, hypertension's crossing the line before the rest of these guys are even in the backstretch. Okay. Affects over half of patients over 70 years of age, and by the time you get to 80, it's over 80% of patients actually. 40% risk reduction for every 12 millimeters systolic drop in your blood pressure, which is about what you get from almost every antihypertensive agent you take. most antihypertensive agents will give us somewhere in the range of 10 to 15 millimeters drop in your systolic pressure. So if you're running around 180, it's highly likely you're going to need at least 3 agents to get you down into an appropriate range for blood pressure management, below 140. Okay? So those are the sorts of relative figures that are important to...
There's allergies on this vascular disease here. Allergy?
Allergies, not much. It'd be pretty slight. Yeah, it'd be a very small component of the whole business. This is just a graph showing the relative risk increase of increasing blood pressure levels. Here with these different 3 colors, the white filled bars down here represent people whose blood pressure is less than 140 on 90. The black ones, those are between 140 to 160, and those who are greater than 160 are in the red. And you can see the rising risk of annual incidence of cerebral infarction per 1,000 persons when your blood pressure starts to get up into these sorts of ranges, depending on your decade of life. You can get away with it when you're young, as your friend probably is, but the older you get, the more certain it is that it's going to catch up with you. When you get up in here to your 75, if you're running pressures that are over 160 systolic, you're running about a 1 in 4 chance of having a stroke, which is huge. Frightening.
75 to 84, you're better to have slightly higher blood pressure.
Well, this is just because of the small numbers of patients in here, actually. It's the one thing where there's a slight anomaly in this. But if you look at the trend here on every other decade of age, this is just a statistical anomaly, is what it is, really. And the key thing is, this is the big number to look at. And you're looking at, for instance, here, compared to someone with normal blood pressure, you're running 68 over 5. That's about 14 times the relative risk. Here, even if you take except 83, 23, it's around 3 times the risk here. 94 over 22, you're about 4 times the risk of having a cerebral infarct. It's huge, and it's such a treatable, measurable thing. You just have to make the effort, go and get it measured, get it done properly, or buy an appropriate device, check it at home, and have it treated. Okay? It's the same thing in women, same sort of a story. And here it holds true in all 4 of them. Again, huge ratios and differences in risk. I won't worry about that one. TIAs. TIAs, as I said, that we probably should have called these transient stroke syndromes. And we've been going on for pretty late. So Bob, give me a shout if the snoring's starting to get to you.
I think everybody's on the edge of their seats.
Okay, all right. So transient ischemic attacks, and I think we really should have called them transient stroke syndromes. It brings it more into the common man's terms that he can understand and grasp. And the reason for that is because TIAs are actually chest pain of the brain, just like angina, which comes for 5 or 10 minutes, goes away, is a symptom of what the same sort of process that can produce an MI. It comes for 2 or 3 hours and leaves you with a big myocardial infarct. Well, a TIA, or a transient stroke syndrome, is a symptom of the same mechanism that can produce a permanent stroke syndrome down here. It's just a matter of size. It's the same beast. It's just a matter of size and good fortune as to whether or not the clot breaks up and your syndrome is transient, or the clot doesn't break up and you end up with a permanent stroke syndrome. Okay? So let's just go back and we'll look at this definition. These are episodes of transient. They usually last, the majority of them last 15 to 20 minutes, but they can last as long as an hour or 2 hours, although when we start to get into that range, most of them are strokes, actually. But they can be anywhere between 5 and 30 minutes for the majority of them. Focal neurological dysfunction. So it's not a transient episode of the dizzies or the woozies. It's a transient episode of paralysis or an arm that doesn't work, and you can't pick up your cup, or you can't handle your knife and fork. Or it's a transient episode of speech arrest where you just can't get any words out and you can't communicate for 20 or 30 minutes. It's a transient episode of blacking out of vision in one eye, this amaurosis fugax we talked about earlier. and it typically approximates the vascular territory. But the thing you need to know is it may be transient, but it's every bit as important as one that isn't transient. This is, if it's transient, thank your lucky stars, but call 911 and get your tush into that emergency room, okay? Fast as you can. Like I say, average duration 10 to 15, most are less than an hour, and most, about a quarter of strokes, 15 to 20%, are preceded by transient ischemic attacks. Your risk of having a stroke after a transient ischemic attack is between 5 and 8% in the first 48 hours, the next 2 days. So it's not a time to dally or fiddle around. And our whole system of stroke triage and management of people with TIAs is geared to investigating people in rapid short term right there in the emergency room, getting it all done really quickly. It's often a symptom of more widespread vascular disease as well, and your risk of an adverse vascular event at 3 months is nearly 25%. That's huge. MI, coronary insufficiency, various other forms of vascular problems, okay? It's a very important issue. It's sort of a front-end loaded risk curve. So here we'll just finish with this one slide here showing the risk factors again, just to refresh your memories. The only other slide I probably should have up there is the warning symptoms of a stroke. And you guys are going to tell me the 3 warning symptoms of a stroke in order, right? What's the number one important? Weakness. Sudden loss of strength or function in one limb usually, or one side. Weakness. Number 2? Speech. Okay. Vision's right in there close. Okay. And then vision. Okay. Those are the 3 big ones. Okay. Remember those. You don't have to have all the 5 fingers on there. That's too hard to. I can't remember 5 things. God. Okay. Any questions?
Someone mentioned vitamin K, notably vitamin K2. Would you comment on how this can help reduce the blood clot?
Well, I don't know that vitamin K2 is of any benefit in reducing the development of plaque at all, actually. The only ones that have been suggested as being helpful are when people have very high elevated homocysteine levels, vitamin B12 and B6 thiamine, or B6 and B12 are a benefit. Those are useful.
How about vitamin C? Someone, the doctor told me, you better take the first thing in the morning. Half an lemon with juice and water, lukewarm water.
Yeah, I think vitamin C is a good thing overall, generally, actually. It's a bit of an antioxidant, and I think that's a part of it probably relieves a bit of oxidative stress. All the antioxidant stuff hasn't panned out very well in terms of, proper scientific controlled experimental trials. But vitamin C is a good idea. Generally, yep.
What about pressure headaches occasionally? What effect do they have on your circulation?
Well, they don't have much. Most pressure headaches, most intermittent pressure headaches are migraine. Migraine's really common. It affects 1 out of 1/20th or 20%, 1 out of 5 people in the population. It's very common. So if you over the years have had recurrent, intermittent, sort of unpredictable headaches, which are worse when you sneeze or cough or bend over, and they feel like pressure in your head, maybe they're associated with Chinooks or something like that, those are migraines. Okay? But they don't put you at any more. It doesn't put you at any higher stroke risk. Okay.
Just a little thank you from Calgary. Thank you very much, Tim. Really